So good morning, everybody. I know people have been waiting for this talk, grand rounds given by one of our professors. It's a little embarrassing trying to introduce somebody you all know, Dr. Sekhar, but I'll try just for a minute because obviously I can go on if he was a visiting professor for 10 minutes, but Sheikh, as we know him, and you see he's the Laligam Bennett Bigelow professor and vice chair, but he was born in Madras, India, and he trained in Pittsburgh for neurological surgery, and he has been longest at the University of Washington, 18 years. To sum up his accomplishments, it would take a great deal of time, and then we wouldn't hear his great talk. Needless to say, he has produced over 300, almost 400 peer-reviewed papers, 200 books and book chapters. He has the highest impact factor in the department of close to 90. And he is gracing us with a talk about one of his inventions. And so, Sheikh, I didn't take much of your time, so you can talk to all of us. Everybody, all of you know who he is. He's a spectacular surgeon, a wonderful colleague, and a world-class educator for our residents and medical students. Sheikh, tell us about your new device.
So thank you, Professor Ellenbogen. First of all, wanted to thank all members of the University of Washington Department of Neurological Surgery and other members of the University of Washington. Your support over the years has been vital for my life and my growth here, and Rich particularly. He and I have been friends for a long, long time. I don't even want to tell you how long. And many people here. So anyway, I thank you first of all, and we'll talk about this. This is intracranial venous flow has been an interest and passion of mine for a long time. We now have something, perhaps we are able to impact venous outflow, and it may in turn have some effects on ICP, intracranial pressure, and glymphatic flow. So to talk a little bit about cerebral circulation, and very briefly, for those of you who may or may not have thought about it in the past, so you have arterial inflow, you have capillaries and glymphatics and venous outflow. So the arterial inflow is determined by the cardiac output, and then you have a set of what we call conductance vessels. These are pipes that normally just conduct the blood. The common internal carotid arteries, their primary branches, vertebral basilar vessels, and so on. And then these branch down and go to what are called the resistance vessels, which are the arterioles. And then the blood keeps flowing on. Intracranial pressure, blood viscosity, and our red cell count are important factors that have an impact on the inflow. Then you have capillaries through which the fluid comes out, the extracellular fluid, and then it goes into the intracellular space. And we'll talk a little bit about this later, but then it seems to mix with cerebrospinal fluid as well. And this whole circulation has been recently termed the glymphatic circulation. And then you have the venous outflow. So you have the venules, which are called the capacitance vessels, because they can dilate and contract, determining the blood volume inside the head, which then leads to the veins, which are both superficial and deep. And then venous sinuses, superior sagittal sinus, transverse sinus, cavernous sinus. These are the major sinuses, and then they have collaterals. Finally, they exit by means of the internal jugular veins. You have emissary veins, you have the pterygoid venous plexus, and also vertebral venous plexus. So what determines cerebral venous outflow you have the forward pressure from the arterial circulation, and that's called the vis tergo. And then, of course, you have venous capacitance vessels. They can constrict or dilate. You have gravity-induced negative pressure inside venous sinuses. Also, the atrium, when it dilates, creates negative pressure. And breathing, respiration creates negative pressure. And the veins, especially extracranially, they can collapse or dilate, and then they have valves. So when you have acute obstructions to flow, it creates problems. Chronic obstruction can be overcome by collateral circulation, and thrombotic tendencies also are important. For instance, factor V Leiden mutation can create some issues. So here in these studies, you see the typical type of pathways that we see with the venous circulation. So you have the superficial cortical veins draining into the superior sagittal sinus, and then here's the deep venous system going to the straight sinus through the internal cerebral vein. This is the vena labae, and here's a middle cerebral vein draining into the cavernous sinus and then on to the pterygoid plexus. Important to note in this individual that there's a very prominent emissary vein which is draining out of the sigmoid sinus, and you're also seeing some of the vertebral venous plexus. And there is a lot of variation. We're actually now studying it in about 100 normal, quote, normal patients. What are these variations? Here's another example. In this particular individual, you see that there are the main drainage is through the internal jugular veins, and there's hardly any emissary vein, and there's very little venous outflow through the pterygoid venous channel. So there's a lot of variations, and of course, once you have obstruction, then the body nature finds a way. So we came up with this idea of enhancing the venous outflow of the brain. Enhancement may mean improving the volume or speed of venous outflow. And the concept is to enhance the flow by means of external peristaltic massage. And the goal of this is to improve the venous outflow, to reduce intracranial pressure possibly, but also possibly improve cerebrospinal fluid pressure or the cerebrospinal fluid and glymphatic flow. So what is the glymphatic circulation? We talked about this earlier, and it's a network of extracellular and perivascular pathways. Cerebrospinal fluid circulates around the brain extracellular space, and it's hypothesized to clear the metabolites from the glymphatic space. And clearance of brain metabolites could possibly improve cognitive function in some patients with dementia. This is hypothetical. There's a lot of research taking place in different centers, and it's particularly at the University of Washington as well. So what is our device, the overview? We've called it now the Augment Flow device. It's a wearable device. Initially, we had conceived of it for astronauts in space because there's no effect of gravity. But our first grant was rejected because they said that you don't have any proof of concept. And then we went back to the bench and created this device now, and we think that the market is, of course, much bigger for improving intracranial pressure. So we devised it. So the concept is a device that'll fit as a collar around the neck, and there will be a peristaltic massage of the internal jugular vein low in the neck, because this is the area where the common carotid artery and the internal jugular vein diverge. So when you massage something, you're not impacting the carotid artery. And then, of course, we had to get it through IRB. So the pressure is very regulated, strictly regulated. Maximal pressure is 15 torr, and we'll come back to this. We have to make sure that we're not having any impact on the arterial circulation. So this is kind of the model of the prototype, and currently we are performing safety studies in volunteers, and we have made several, and then we are making even more changes based on initial testing. This is the initial mannequin model that we devised to help devise the device, but as we went on, we have given this up because this doesn't really reproduce the intracranial and extracranial physiology. So what is our research plan? We have safety testing in normal volunteers in the cerebrovascular lab at Harborview Medical Center. And we'll come to the protocol, but we want to make sure that there are no adverse effects of any kind on the brain. And then optimize the existing prototype based on the feedback. A number of changes have already made. And then we want to move on to an MRI compatible device. And why? Because we are, with the MRI device, we will be able to see concurrently with the activation of the device what's happening to the intracranial venous circulation. And then also simultaneously perform four-dimensional computational modeling of venous outflow, and then get investigational device exemption and start phase 1-2 clinical trials in patients. So what's happened since 2022? We have achieved IRB approval. This, of course, they have to be very, very cautious because this is a completely new idea, and we are having possibly some impact on cerebral circulation, etc. So lots of things back and forth. So we got IRB approval. We've actually filed a U.S. international patent. The University of Washington Department of Innovation has been very, very proactive and very helpful to us. The device was then evaluated and approved by HMC Engineering Department. We made certain changes. We have a small NIH grant. It's called the WeReach. We have a much bigger grant in process. And then we are, depending on the outcome of this grant, we also planning an SCTR grant in January. So what's the study design in the TCD lab or the cerebrovascular lab? They have restricted us to a group of people 20 to 45 years. So they have to be healthy without a history of stroke, cardiovascular disease, etc. First, we do carotid duplex imaging, make sure that there's no significant disease. And the volunteers are, of course, they receive informed consent. They are actually paid something for the study. They're all kind enough because each study takes about an hour. 9 of them already have undergone the study, but the study was paused because we had some problems where we lost 2 positions in the CV lab, and they were really strapped for research time. So now it's sort of that problem has been resolved, so we'll resume the studies. So the patient is essentially lying supine. We check their blood pressure and pulse oximetry. We have probes on the temporal area to monitor the middle cerebral circulation, particularly look for emboli. We do cervical duplex ultrasound and image the internal jugular veins, and the device is positioned in the lower neck, and we obtain baseline data. Our initial idea was to simultaneously, with the activation of the device, to look at the venous flow, but the problem is the device itself is bulky that we're not able to do it. So we actually look at the venous flow in the upper neck before and about 5 minutes after the activation of the device. This is a very important point. Also, you have to keep in mind that when we're looking at the venous flow in the upper neck, it is not 100% a reproduction of the intracranial venous flow because there is already some mixture with the facial veins. So this is what our current device looks like. Basically, initially we started with 3 rollers. Now we reduced it to 2 rollers, and then we cover it with a glove, a cut glove. This we found to be the best membrane, and then this is discarded so that it's more or less patient-specific or person-specific. There is a battery-operated device that activates the rollers. We can do either one side or both sides. We are currently just doing both sides simultaneously. And we are looking at the middle cerebral circulation. And then here is Dr. Sekhar lying down and getting the test with Ann Moore, who was the former director of the TCD lab. She was doing this test. And here is a typical study. This is our subject number one, namely Dr. Bharat Shenoy, our research fellow. So you can see that we are monitoring the TCD in the middle cerebral simultaneously. We are imaging the vessels in the neck, and we have two machines, normally actually three machines, two machines and then three monitors look at the flow. And then this is placed on the neck and activated. So these are some representative studies. We have about 9 patients, and the results are interesting. And keep in mind that we are not able to image concurrently with the activation of the device. So, and also one more thing is that we are kind of estimating the flow based on a formula in the machine. So the machine looks at the diameter and the flow velocity and estimates the flow. It's more accurate for arteries because the arteries have a circular shape. Veins have an oval shape. It's not the best, and also veins are somewhat collapsible. So we are estimating the flow. And here the left and right internal jugular vein flow, and you can see before anything is done, 320 mil per minute and then 80 mil per minute on the right side. So the left one is dominant here. The other thing to note is that we're looking at an approximate volume and not speed of flow, which is very important as well. Now, 5 minutes after the activation of the device, the flow has decreased in the left IJV and increased in the right side, and the net flow is the same. So it may well be, the question is why. We have some hypotheses. It may well be that there is some hyperemia and then it quickly equilibrates back to its normal self. This is a second subject. The flow in the left IJV and the right IJV is in fact low, which indicates that the subject may be getting venous outflow through some other venous channels. And then after the activation of the device, there is about 5 minutes later, there's actually a net decrease, once again raising the question of whether there was some hyperemia. And the subject number 3 here, the flow is very high to start, and then on the left side and then the right side, and there is some equilibration of the two sides, and the net flow at this point is very similar. So what we are able to establish with the 9 initial subjects is that there is actually some effect by activating the massage device. There is probably some hyperemia taking place, but also there may well be some compensatory ischemia or reduction afterwards. And this is just something that so far we've been established. In the 9 subjects, no adverse effects of any kind was notable. And this is just one more subject. And here's a compendium of the 9 subjects. It's sort of, results are in basically in 2 patterns. We find that compensatory increase, normalization, or slight decrease. So what are some of the drawbacks of measuring or checking the venous flow in the upper neck? I mentioned that we are not able to look at it concurrently with the activation of the device. So we have to do it before and after. Whereas if you have the device in the MRI scanner, we can actually look instantaneously what is happening to the venous flow, and we can measure both the speed and volume of the flow. And also, I mentioned that there are maybe other channels, and so it may be that the rollers have to be also placed on some other locations. And there are questions about whether one should only activate the roller on one side, that is namely the side of the dominant sinus, versus both sides. So what we are now engaged in at the moment is devising or fabricating an MRI compatible device. And we've already done some work. We are fortunate to have the collaboration of an outstanding engineering team. And I'll tell you about the names of the people at the end, but they actually have a 3 Tesla magnet in their department, and we are testing individual components. And what we found that there are almost a number of the parts of the device we're using are MRI incompatible. So here's the testing bench. You can see that there are 2 coils, and this goes up to 3 Tesla, the MRI, and we have a camera, and the various parts are suspended on a string inside, and then the MRI is activated, and we are actually looking at the deflection of the device. So what we found, for instance, is that there's a program called a tracker, and it tracks the deflection. You can see here how as soon as the MRI is activated, this nut, basically steel insert, is MRI incompatible. So we can replace it with a plastic piece. And almost every AS component we have to replace. And there are some issues as well. We are just doing the testing. We completed the testing, so we had to move on to the MRI compatible prototype. The other thing is that we also want to tweak the existing device, because we have at the moment a preset pressure of massage, but we want to actually also be able to measure what is the pressure exerted on the skin surface. So to this extent, we have a pressure sensor which we're incorporating. And lastly, we want to have a monitoring system which displays everything simultaneously. So the question that is raised by a number of the researchers, then when your goal is to reduce ICP and maybe improve lymphatic flow, but what is the quantitative link between improvement of venous flow? Let's say that we can improve venous flow or the speed of flow, and intracranial pressure. And this is not established at all. I mean, this is still hypothetical. And to establish this, then we have to show 2 things. One is there is improvement of venous flow, and secondly, there is we have to do some 4-dimensional modeling. And of course, the proof of the pudding is eventually in doing phase 1 and 2 studies. And then our plan is, with the help of Patrick Fillingham and Mike Levitt, to develop a 4-dimensional computational model of brain venous flow. And the MRI data, again, will be very important for this part. And all of this is going to lead to clinical trials of patients in the intensive care. Will be conducted, we think there will be 2 places: Harborview with the help of Dr. Bono, Dr. Lele, and Dr. Levitt, and at Santa Clara, Stanford University, Dr. Marco Lee and his team. And this is about at least a year away. So we have about a lot of things cobbled together and on a shoestring. A lot of different contributions, including Department of Neurological Surgery, Co-Motion Innovation Gap Fund, and then we have WeReach funding, and then patient donations, etc. So it's a very big team of people, as you can imagine. Neurosurgery, Dr. Shenoy is a research fellow. Dr. Karunaharan, he's a space medicine expert and ENT surgeon in the UK. And then we have one medical student who's working on this. Very important, UW Mechanical Engineering Department. Anirudh Vasisht is the principal lead on this. And then we have Professor Mamidala, who started with us. And then Vikram Iyer, who's just joined the team. We have graduate student Arun Nandagopal, Daniela Sekhar, who was working on this during the summertime. And then we have people in the cerebrovascular lab, technicians. And then the clinical trial team, who have contributed, in terms of concept, but not actually done anything yet significant because we're waiting for the clinical trials. Computational model development, and then neurology and radiology. We have first Dr. Mike Williams, Gotke, Dr. Mosa Basha, and then in the MRI scan, Jeffrey Alif and Swati Lewandowski, they are going to be working on this MRI device and studies. So there are a lot of questions about something like this, which is, which is an absolutely novel concept. The first an important question is it actually possible to improve the venous outflow from the brain or the speed of outflow? And then the second thing is, what should be the duration of this massage device? And then, well, should we do it unilaterally versus bilaterally, frequency and other parameters? And then the question leads to, will the improved flow actually decrease elevated ICP, and for how long? And will improved venous flow improve the CSF flow or the lymphatic circulation? And the most important question of all these is, will the external reviewers buy these hypotheses and give us more money for research? So I would like to stop at this point, and would like to open up the floor for questions. I think that all of your questions will be very, very important, and the comments will be very, very good here.
Any questions, folks? Sheikh, what's the, let me ask you a question. It's fascinating. And I know there, people have thought of devices to increase venous outflow or obstruct there's that device to obstruct venous outflow to decrease concussions and, those thoughts, crazy ideas. But, let me ask you about this. What's the biggest risk? What's the biggest danger of this device that you can think of, that if a reviewer came, you'd say, yes, I've thought about that?
Yeah, I think there are two big dangers. One is that this massage will have some adverse effect on the arterial circulation. So because we are actually doing a peristaltic massage in the direction away from the brain, and we could somehow impact the, compress the carotid artery, and that then leads to embolic stroke, etc. So that's why we are, in every person, we are imaging and then localizing the device precisely. So when you get away from the common carotid in the neck, then you're in good shape. It's pretty safe because it's further away. And then the further back you go, you're in good shape. The vertebral arteries are well protected through the canal. They run through the canal they enter the foramen pretty low. And the other thing is, the massage pressure is set such that it's a very low pressure. So it'll have no impact. And we've seen so far in our studies, and that's only 9 subjects, we are planning to do 20, we have seen absolutely no impact on the arterial flow. So that's the number one thing. The second point is that our goal is to improve our decrease ICP. It actually could have the opposite effect. It may actually increase the ICP. That's some sort of a paradoxical effect is also possible. So this is some of the things. These are 2 things that we'll need to look at. Lastly, there could be local factors, skin irritation, etc. And these are also potential side effects.
Thanks, Sheikh. I think that's great.
I have a quick question. So, Sheikh, interesting stuff, and I admire your tenacity and having this idea and really pushing for a long time to get this to even to the point it's at now, which is just, it's been impressive. I guess from a scientific standpoint, I am wondering, even if the device itself doesn't turn out to do what you want it to do, what do you think is what are the scientific gains or scientific merit that comes to you from developing this? I mean, you're already seeing some of the like the test rig that you've designed and some other things that you're working on, it seems like there's a lot of potential offshoots for the study of cerebrovascular and glymphatic flow, both on a benchtop and also radiological, maybe computational. Even if the device never sees commercialization, where do you think the scientific gains might be best realized?
Those are actually very good questions, and are obviously going to be coming from a top-grade scientist such as Dr. Levitt. The more we dig into it, the more we are finding out about intracranial venous circulation. The very first thing is that as I showed earlier, we now started to look. We have studying the patterns of venous outflow in 100 subjects. A medical student, Craig Hefflick, is working with us. And we already noticed that there's differences in the venous outflow pattern. The second thing we found out is that no one has truly quantified how much venous outflow is going through the various pathways in normal subjects, not people with dural AV fistula or various forms of venous obstruction, etc. So that's another thing. And then what is really the correlation between venous system and the ICP and the lymphatics, lymphatic flow, etc. Again, we are digging into this. The more we dig in, the more information is coming out, and it almost seems like there's going to be like 10 years of work in this from a scientific point of view. We have to keep an open mind and look very carefully and cautiously in everything. We just haven't thought about it so much in the past. Well, I've thought about it, but I mean, maybe the technology wasn't available. So I think we are going to find a lot of information, and also based on the only method that exists in astronauts to improve venous outflow is putting them in a G suit and exert negative pressure. So they actually go into a G suit periodically. So the whole thing exerts negative pressure to suck out the blood from the head, which is impractical, of course, in even for astronauts. So the idea of external peristaltic massage is itself a pretty novel concept. But beyond that, there's a lot of aspects to this which we will discover. We have to, as always with research, you find things that you have to keep an open mind, and the smarter the people that are involved in it, lots of things will come out.
Thank you. And then just a brief kind of secondary thing that I've been thinking about. I think it's going to be important as we move forward with this in sort of human clinical trials to consider validated headache instruments as an endpoint, because there might be a link between cerebral venous outflow obstruction and some headache syndromes. And so it might be interesting to track that and see if that's a quote unquote side effect, which would be a substantially larger market than any market that we're investigating for medical use, and sort of then you sort of win the lottery. But there's a lot of emphasis on pain and headache in particular through the NIH, and there's a lot of what I would consider like Trojan horse grants. We're a sub investigators on a grant from University of Florida looking at parasympathetic blockade for headache related to vasospasm. So this is a vasospasm grant funded by the NIH, but the primary outcome measure is headache. Mm-hmm. And oh yeah, by the way, we're also treating vasospasm. So thinking about those things, you can sometimes get a little bit of additional leeway from grant agencies. So anyway, it's an interesting engineering problem for us that our group, Dr. Fillingham and myself, have been working on for patients with IIH and venous outflow obstruction, separate from any device development. So it dovetails nicely with our work.
Yeah, Mike, what about that? What if it did help headaches? I mean,
then I'd like stock in the company, and that'll be fine.
Exactly. I mean, Sheikh, one of the things I agree with Mike, one of the things you should certainly track in this is headaches, because it could be, one of those things that 90% of people's headaches went away. I mean, that would be crazy, but it's very possible if you increase venous outflow.
Yeah, the other thing also I'm thinking about doing is very interesting. I did some as always, some test studies on myself where I was doing some sort of a yoga posture where I put the head down, all the way down, and for 5 minutes, and then we came back to an erect position. And I did this a few times, and I was very tired going into for some reason I was, one of these things, maybe I was operating the previous day or a jet lag, and suddenly I found my brain was feeling better, clearing of something. So one of the other things to investigate here would be the idea of wellness, whether a person may feel better, their brain can feel better. Of course, we in order to establish or evaluate this scientifically, we got to do some, mini mental status exam before and after, and this may actually have some correlation with the idea of lymphatic flow as well. So these are all things that definitely down the road. And how do you measure lymphatic flow? Actually, it's very interesting. They actually do the MRI studies in the MRI scanner. We're looking not just at the venous flow, but then they give an intravenous contrast tracer, and then we're going to be we'll look at CSF flow like we do in Chiari patients, but also they look at the clearance of the tracer from the brain. So it's a little bit more invasive, that particular study, but nevertheless, that's kind of where it might be headed.